TMB is probably the most well developed in this field. And the background behind that is that a lot of the early studies that used whole exome sequencing and looked for genomic correlates noted that the TMB in patients who responded is often higher than in patients who don't respond. And this was initially demonstrated in studies that used whole exome sequencing and looked at melanoma, and has since been confirmed via a number of different sequencing techniques and also in a number of different disease contexts. And there has been a lot of interest in developing it as a biomarker, and as of June of this year, it also received an FDA approval with pembrolizumab in the second-line setting. So it is now FDA approved. Other biomarkers, I think, are not as well developed. So in lung cancer, one that comes up quite a bit are STK11 mutations, and my colleague Fernando Scalitas has worked a lot on those. I think STK11 generally is a poor prognostic marker across different treatment settings. And there's also some other work showing that the presence or absence of other co-mutations such as TP53 or KRAS informs how detrimental the STK11 mutation is. So I think there's a lot that we still have to learn about that. I think in lung cancer, we kind of take for granted that we tend to use driver mutations as biomarkers like EGFR, ALK, ROS1. Those patients tend not to respond as well. But I think we also have to be careful that we don't extend that to all driver-altered non-small cell lung cancers. I think BRAF and MET may be biologically a little bit different. So there's a lot that we're still learning about these other biomarkers that will be exciting over the next couple of years.